that's kind of what I do. So an air change means the volume of a room going through usually in an hour. We talk about air changes per hour. It isn't like a piston that all the air goes in and all the air leaves. Fresh air comes in, mixed stale air goes out. In a perfectly mixed room, which we don't always have, that means 63% of the contaminants are removed by one air change. And the next air change removes 63% of what's left. And the next air change, 63% of what's left. CDC suggests 6 to 12 air changes for hospital isolation rooms. Most homes have a fraction of an air change or an air change, depending on how tight and new the building is. Offices, we mostly talk about ventilation per person, but on the order of 2 to 4 air changes per hour. Most ventilation systems are not designed to deliver more than that. Even it's not that they're in bad shape, they aren't designed for more than that. So it's really hard to get much more than 4 air changes in a school, I would think, depending on how the system is built. This blower speed, the size of the ducts, and ironically, some of my engineering colleagues, you know, as soon as you start talking about a air contaminant, they either want to ventilate it or filter it. So they're talking about putting higher resistance filters in ventilation systems. And I have 2 problems with that, which I'll talk about in the presentation in more detail. But one is that you can, by virtue of putting in a higher resistance filter, reduce the flow rate and actually make things worse, because you can't generate as much flow with a high resistance filter. So in fact, I was asked to talk with the head engineer at Copley Place, and he was under a lot of pressure to put in filters in his system. And he said, I know that if I put filters in here, I'm going to get less ventilation. He said, is that, you know, could I put UV lamps in the ducts and do the same thing? I said, you can, but he was absolutely right that, you know, you may be able to put better filters in depending on the details or not. My main issue is, to me, it's what's happening in the room, not after the air leaves the room. That is the issue. So focusing on filtration is focusing on the wrong place. It's possible that COVID virus could recirculate and come back, but everything we're learning suggests that that isn't happening. It's proximity to the source that matters. And as you get further away from the source, the risk goes down, whether it's large particles or small particles that are being diluted. Once the air gets into the ventilation system and is diluted by air coming from many other places in the ventilation system, the chance of getting an infectious dose goes down dramatically. So I'm not terribly worried about the level of filtration. Sure, if you can put better filters in, do it without reducing the flow rate. I am concerned about how much flow rate there is and whether or not you need to supplement that with air disinfection. And that's my argument. So 4 air changes, you have to also ask the question, is that outside air or is that total air? Usually they're talking about, oftentimes it'll be 4 total air changes, one of which is outside air. Normally, ventilation systems bring in anywhere from 10% to 20% outside air, and if it's really cold outside, it may shut down to no or very little outside air. In that case, you are rebreathing the same air, but again, dilution in the system helps you a great deal with this particular infection, which seems to require a substantial dose, and you need to be close to the source.
Does that help you, Lori?
Yeah. It helps me to understand better. I don't think I'm ever going to know the exchange rate because my district is refusing to do it.
So the way that would be done, and it isn't $1 million. How many millions did you say?
Instead of a half million.
It's not $500,000. There are sophisticated ways to use tracer gases to come up with. You put a tracer in the room, and you see how quickly it is diluted. Those would be expensive. Normally, what's done is people put a big device on the register of air coming in to measure the flow. And if you measure the flow, you then can calculate by virtue of the room volume what the number of air changes is. You look on the specifications of the building plan and you see whether it's up to specs or not. And then you should be able to know what the percentage of outside air is, and then you can figure it all out. So that is a fairly simple measurement that any building engineering consulting group can do, and they shouldn't charge a hell of a lot for it. Frankly, any engineer, any HVAC engineer should have a volumeter, that's what the thing's called, to be able to do that. So it's not a big ask, but if they don't want to do it, they don't want to do it. Now, one other comment on ventilation. If ventilation is really bad, 1 or 2 air changes per hour, that can really make the situation much, much worse. But again, there's a limit to how you're not going to get to 6 to 12 air changes with ventilation. It can't happen in most buildings that are designed for comfort. Ventilation is designed for comfort, not for airborne infection control. And so as long as you don't perceive odors and you can deliver heat and air conditioning, a ventilation system in a school is doing its job. If you want air disinfection, in my view, and again, most HVAC engineers don't know about some of the alternatives because it's not been an issue. Airborne infection hasn't been on their agenda. They're trained to provide comfort level ventilation. But if you want to talk, if you have to supplement ventilation with something else, there's really only 2 alternatives, and that is air cleaners or upper room germicidal UV. So perhaps, Scott, it looks like you've got more people. Shall I do this presentation?
Yes, please. Yeah, that'd be fantastic.
You'll have to give me permission to share my screen.
Oh, okay.
This is about 20 minutes. It's a presentation I gave yesterday to the Academies of Science, Medicine, and Engineering, a national conference that we had on germicidal UV. Okay. And find a way to do this. All right. So I'm going to talk a little bit about COVID transmission and then get on to what I was just talking about, alternatives. So is it airborne? Won't go into this in great detail. The evidence is so far circumstantial. It's not as nailed down as we'd like, but there seems to be quite a bit of consensus, despite the fact that the WHO early in the epidemic said it's large droplets and that's it. I was part of a letter to the White House, requested by the White House, asking whether COVID was airborne, and the Academy of Sciences said, yes, the evidence is compelling, and this is some of the, is suggestive, I should say. The evidence is here. First of all, you can find the virus in the air, in large droplets and in small droplets, either by doing what's called a PCR test, looking for DNA, RNA, or by culture. Other similar coronaviruses, SARS and MERS, have had airborne components. There was this chorus in Washington State where 40 or 50 people out of 60 were infected in a 2.5-hour rehearsal. They were instructed to not touch and not to come if you were sick. So this was unsuspected COVID and most likely airborne. As I mentioned, I sing in a chorus, and I got infected with COVID in March. And there was a Hong Kong apartment building that was associated with SARS transmission. There's another Hong Kong apartment building where transmission occurred between floors among people who did not have any other form of contact. That's very hard evidence of airborne transmission. This one has not been written up as a scientific article about COVID. The SARS one was. There's a Wuhan restaurant where it appears that transmission went from table to table in the direction of an air conditioner. Again, that isn't really hard evidence because large droplets could also travel by airborne route. Now, why are we making such a fuss over large or small particles? There really is a spectrum, and it really doesn't matter that much, except that mostly large particles will settle within, usually we say 2 meters or 6 feet, but under certain circumstances, they may go further. Small particles really become part of the air, and that's where air disinfection and other things come into play. Both of them behave as if distance matters, because if you're close to somebody who's generating large particles that could land on you, the further you are beyond 6 meters, the better, 6 feet, the better. And if it's small particles, they get diluted as they move away from the source. And so it's really hard to make that distinction. You can understand why that's hard. I'll be telling you about other evidence of transmission as well. So here's an interesting slide, which actually found on the internet, and it's looking at states in June and their increases in cases, 50% increase, 100% increase, 150% increase, and how many cooling days they required. And so I need to get rid of this. There we go. You see in the states that required the most cooling are the hot states: Arizona, Florida, Louisiana, Texas, and lo and behold, they seem to be on the upper end of increases in COVID. And the cooler states, Massachusetts included, Rhode Island, et cetera, tended to be in the lower end of actually having cases go down in June after having had a lot of transmission in the winter months. Well, what happens when you turn on air conditioning? You have to close the window, and therefore in homes, et cetera, and also if it's terribly hot and you go inside to a restaurant or whatever because it's cooler, you're not as socially distanced, and you are rebreathing the air that other people just exhaled in a recirculated situation in a room. So again, circumstantial evidence. Now, here's some more scientific evidence. This is a paper by Rachel Jones, just published, doing modeling, and I won't go through all the details of the modeling among hospital workers, but the conclusion is, of the 3 routes, droplets, inhalation of small particles, or contact, droplets she thought was 35%, inhalation 57%, and contact, despite the fact that we've been Clorexing everything under the sun, only 82.2% of transmission. Now, this is a hospital setting where everything tends to be cleaned, so that may account for this low number. In the real world, it may be slightly higher, but I've even heard Anthony Fauci say that, yes, it may be spread by contact, but maybe if you had unsuspected COVID and you sneezed into your hand and grabbed a doorknob and somebody immediately grabbed it after you and then touched their eye or their mouth, they might get it that way. But that is a lot of ifs. We've been acting as if every surface is infectious, and that's probably not the case. Where is transmission occurring? And I made this point earlier for those who just joined. I believe it's as in the Hamilton play, it's in the room where it's happening that really matters. And so you have a source of aerosol in the room and you have people breathing in that air, I'm not terribly comforted that when the air leaves the room to go into the ventilation system, that we put in a filter that stops it later on. What about what's happening in the room? Filtering the air after it leaves doesn't do anything to stop transmission in the room. And yet that's what a lot of HVAC engineers are recommending, is, put higher level filtration in your recirculation. What matters is how much air is coming into this room, how many air changes. And if you don't have enough air changes, if you have an old system or a system designed for comfort, which most are, then you need to supplement that air disinfection some other way, either, again, making more ventilation, room air cleaners, or upper room germicidal UV are the options. So I wrote about the impact of air conditioning before COVID happened, mostly referring to poor countries, and in particular, increasingly hot countries, where air conditioning use is increasing dramatically. So here we see in India, air conditioning sales going up, 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 up. And most of these are what are called split system air conditioners, where there's no outside air coming in. We're seeing more and more of these in this country, often in restaurants, but I have one in my home as well. They provide no outside air, just cool the air. So the paper we'll see is called Cool But Dangerous, and it implies that when you turn on an air conditioner, you have to close the window, and basically you're rebreathing air that other people have breathed at a greater level. And here's a demonstration of that. In an office building with 5 people, we measured the CO2 levels, carbon dioxide levels, and it was about 700 or 800. Then we asked people to leave and open the window, and then went back toward normal outside levels of 400 or 500. And then we closed the window and turned on the air conditioner, and you see this steep rise in CO2, which shows no sign of stopping. If we had continued this study for a couple more hours, it would be up here. Already, the levels of CO2 more than doubled, and with that, the risk of airborne infection. So this was referring to tuberculosis and other things in poor countries, but it's exactly applicable to what happens when you walk from the outside to the inside of an air-conditioned room. Not only can't you socially distance as much in a crowded bar or restaurant or school, but you cannot, you have the windows closed and you're rebreathing the same air in the room that other people have been breathing, and the CO2 levels can go up. This is just 1 hour. So the options are room air cleaners, and this is just a typical room air cleaner that has a blower in it and takes air in and filters it, or UV disinfects it in the box and puts it out. And the problem with that is you can only move so much air through a box. And it's called the clean air delivery rate, and it's very similar to room air changes. You're delivering so much decontaminated air, but you have to take the volume of the room and ask how many air changes is that? And it turns out for most of these devices put in a room, you get a fraction of an air change. So not much help at all. If you've got terrible ventilation, it's better than nothing. So that's, we're closing the windows in ventilated schools, and you can't have them open in the wintertime very well. So, and mechanical ventilation is limited in a school to comfort levels, usually less than 4 air changes per hour, and not really possible to increase that very much. You've got room air cleaners, which are inherently limited. And then you have this concept of upper room germicidal UV, which is, I'm sure none of you are familiar with. It's not been used in this country very much. It was used in the past, and it was used a lot in the 80s when we had a resurgence of TB, but it hasn't been used much lately because we haven't had a problem with airborne infection. So I've listed most of these limitations. Natural ventilation is fine if you can open the windows and if the conditions are right outside. Mechanical ventilation is, in poor countries, is often absent or poorly maintained, and sometimes in rich countries too, it's poorly maintained. And it's limited. It's hard to get up to the 6 to 12 air changes that CDC recommends, and it's costly to cool or heat outside air. Room air cleaners, portable or fixed, are flow limited. You can only put so much through these boxes, often add 1 or 2 air changes. And they also sometimes recapture the air they just processed and keep going around and round. And then there's germicidal UV, which is can be in the ducts and provides air that returns to rooms less like a filter does. Again, I don't think that's where the action is, but it provides less resistance and is commonly used. And there's upper room germicidal UV, which is very efficient. It requires a little know-how and has some safety issues which are easily managed. And I'll tell you more about that. There's some newer modalities which are becoming on board, but are probably not going to help you by the time you have to go to school this year. Now, not new technology, upper room germicidal UV. This is a 1946 monograph, even before I was born, that talks about and shows you how to use germicidal UV pretty much exactly as we use it now. And it was widely used in the before there were antibiotics and vaccines. And in fact, here is a school outside of Philadelphia, Swarthmore and Germantown, where UV was used in classrooms to stop the most infectious virus we know, which is measles. And this was a controlled study done in 1942. And in the lower classes, where the kids are more vulnerable to measles because there was no vaccine at the time, they put UV. And in the upper classes, where many of the kids had already had measles, so they were immune, they were the controls. And you can see what happened in both schools over this period of time from February to May. There was much less measles in the classrooms that had upper room germicidal UV. And again, this is a virus. It is much more infectious than COVID-19. So how does it work? What we do, and this is showing a hospital room, I've drawn in here a box on the wall, which is putting out upper room germicidal UV across the room. And basically body heat is very effective at bringing air up to the upper room, and then that displaces disinfected air that comes down. To make this work even better, we often use low velocity ceiling fans, typical ceiling fans you find in homes and restaurants, to help mix the air in the room. And that is dramatically more effective than room air cleaners, for example. And in fact, a CDC colleague of mine, Paul Jensen, who was both an engineer and a microbiologist, did this study in Russia, where they compared aerosolizing some bacteria into a patient room and reducing the infectious or the concentration of that test organism by mechanical ventilation and 3 different air cleaners, including this one, very expensive one, that was used in the Soyuz space capsule. And they found that per cost of equivalent air change, that UV, upper room UV, was by far the most effective. In fact, it was about 9 times more effective, cost effective, than any of the other interventions. So in another course that I was teaching in Pretoria, South Africa, there was a salesperson for a room air cleaner. And I asked, well, what's the clean air delivery rate? And they said it was 28.3 liters per second. So we drew a hypothetical room, 4 meters by 4 meters by 3 meters high. So meters about the same as a yard. So 16 feet by 16 feet by, 12 feet by 12 feet by 9 feet. Not that big a room. And that would provide 2.1 air changes per hour in addition to whatever ventilation they had. If you had none, that's better than nothing. But if we put upper room germicidal UV, we could get approximately 20 air changes in that room or the equivalent, or 10 times as much. The way we equate these two things, actual room air changes and UV, is shown here. One air change, as I mentioned, removes 63% of contaminants in the air. The next air change removes 63% of what's left, and the next air change removes 63% of what's left. So you incrementally get lower and lower and lower in terms of risk, but at higher and higher ventilation rates that are very hard to achieve. When UV removes or kills or inactivates 63% of the contaminants, we say that was the equivalent of one air change. So where should it be used? UV, it could be used in healthcare settings, in jails, shelters, nursing homes, and it is being used in many of these settings. It can be used in schools as well, public places where persons with unsuspected COVID are entering. It may not be beneficial in every setting. For example, I did a lot of nursing home visits for the health department early in the epidemic because we had so much COVID in nursing homes. And in that setting where people are being bathed and fed and taken to the toilet, and since this virus transmits by contact as well as by air, I am not so sure that just disinfecting the air would solve the problem in a nursing home, for example. So going back to this slide, again, I just want to emphasize that whatever we do, I think we have to do it in the room where transmission is occurring and not in the ventilation system after the air leaves the room. Although that is not unhelpful. If you can do that too, that's great. It's not going to hurt you unless it cuts down on airflow. Efficacy of this UV, let me just show you a little bit. My computer is loading this slide for some reason. It must be pictures. So awfully hard to show what any preventive thing does. If you get your ventilation improved and you say, prove to me that it works, it's really hard to do that. You can show that the ventilation system is better. And for UV, it's also hard to show that it works in any given setting. All we can do is saying, well, we're meeting the specifications that are known to be effective. I don't know why my computer is stalled here, but seems to be having a hard time going to the next slide. I can tell you what it shows. We did a very careful study in South Africa where we had patients with tuberculosis in patient rooms, and all of the air from those rooms went to chambers that contained literally guinea pigs, like your kids' pet guinea pigs. And it turns out guinea pigs are quite susceptible to tuberculosis. Now for COVID, as test animals, because we do need test animals to study transmission, can't use people. So hamsters turn out to be good models, as well as ferrets. And of course, also primates, which we try to avoid. So anyway, in this study, and I don't know what to do to make this go again. I guess you're seeing the little spinning ball as well. Oh, there we go. Let's get that back to the mode here. And so actually 2 studies were done just as I had described, with patients in hospital ward and sending the air to guinea pigs. And ESCOM in Peru showed about 70 to 80% efficacy. I won't go into detail in that study because I'm going to show you my own study. This one is, again, 3 patient rooms. We send all the air to these guinea pig exposure chambers in these 2 rooms. And we test the guinea pigs, as you've seen here, for TB infection every month. And after, and this is the upper room fixture. You haven't seen a real one yet. And a mixing fan. This could be as well be in a classroom. And we measured, what we did is we turned the UV on every other day in the patient rooms. And on the day when the UV was on, the air went to one set of guinea pigs, 90 guinea pigs. And on the days when the UV was off, on the other days, we sent it to the other guinea pig colony. At the end of months, these guinea pigs only breathed air when the UV was on, and these guinea pigs only breathed air when the UV was off. So the difference between the infection rate on the days when the UV in the rooms was on or off is measured by how likely it is that these guinea pigs get infected in A versus B. And here you see the numbers of guinea pigs infected in the intervention UV room versus the control room. And Christmas came in between, and we had to stop the study and start it again. But at the end of, I think it was a total of 5 months, we had 9 and 48, 50, there were more infectious guinea patients in the second study. And at the end of all these months of exposure, there were 57 guinea pigs infected in the control rooms, and only 15 infected in the rooms with the UV on in the upper room. It's about 80% effectiveness, very similar to what ESCOM found in Peru, the equivalent of adding 24 air changes to the 6 mechanical air changes that were in that facility. This is the paper showing that these kinds of fixtures resulted in those kinds of results. Now, safety. This is a word we hate to use, but it's a form of radiation. It's non-ionizing radiation, not like X-rays. And it's the same kind of light that is in sunlight, except that there is no germicidal UV in sunlight. We have UVA and B in sunlight, and all of the UVC, which is germicidal UV, is absorbed by the atmosphere. So if we want to use germicidal UV, we have to use lamps to produce it. Now, we've been warned for all our lives not to get exposed to too much UV, and really we're talking about the UVB in sunlight. That is what causes skin cancer and cataracts. UVC doesn't penetrate the skin or even the eye to get to the lens, so it doesn't cause either skin cancer or cataracts. Nonetheless, we have an official threshold limit value, the TLV, of this 6 millijoules per centimeter squared for 8 hours. This is for workers, welders, etc., but it applies to anybody exposed to UV at work. And this is meant to be a level that can be used day in and day out. There are no long-term effects of UV exposure because of repair and the fact that your skin is continually shedding, as well as even on your cornea of your eyes. So the only exposure to room occupants is what comes bouncing off the ceiling, which isn't very much. We have to stay within this lower limit to stay within this threshold limit value. So by comparison, if you went out to sunbathe for 2 hours in the peak summer, you get a whopping 240 millijoules per centimeter squared of UVB, which is the kind that penetrates. We're not allowed to expose people in the room to any more than 6 millijoules of the kind of UV that doesn't penetrate. So it's trivial exposure, no effects whatsoever. We did a study in homeless shelters across the United States, and in some shelters we had real UV, and other shelters we had just blue bulbs, and then we switched them back and forth, and there were no eye or skin complaints, more eye or skin complaints compared to placebo lamps. It just isn't a big safety issue. There are official documents on this from the International Illumination Society, and this points out that because UV is absorbed in the outer dead layer of skin, UV germicidal irradiation can be safely and effectively used for upper air disinfection without a significant risk of long-term delayed effects such as skin cancer, and the same applies with eye irritation. There's no reason for it to happen. It is not a concern. So last slide. SARS-CoV-2, the virus that causes COVID-19, it appears to be spread predominantly indoors by both large and small droplets. Many people think small droplets predominate for virtually all respiratory infections, and less so by contaminated surfaces, despite our cleaning for the last 6 months. Spread appears to be primarily in the room with the infectious source, with little evidence at the moment of spread through the HVAC systems, although it's theoretically possible. Upper room germicidal is well established, safe, highly effective, and cost effective for disinfecting air. It can be widely implemented today to reduce the spread of COVID. If you mention it to most engineers, they won't know what you're talking about because it hasn't been used in the United States very much in recent years. Many are anxious to learn about it, and ASHRAE, the American Society of Heating and Ventilation Air Conditioning, has an active committee on upper room germicidal UV to get out guidelines for engineers. There are plenty of guidelines out there already. It's not hard to do, but you need to find some expertise of people who have done it before. People also use high intensity UV in unoccupied rooms and hospitals. And there's 2 new technologies which I haven't talked to you about. There's LED UV, which is simply the LED lamps that we are accustomed to now in flashlights and everywhere else. And you can get UV in that wavelength, and it may be more common in the future. And then there's what's called far UV, 222 nanometer UV, which is also germicidal, also part of UVC, and can be shown directly on people without any, it's even less absorbed. It doesn't even cause eye irritation, but it's brand new, it's very expensive, and limited availability. In the next year, it will become much more common. I think you'll see it in restaurants, coffee bars, nail salons. Between you and the operator, for example, in a nail salon, it would be terrific to have the countertop bathed in 222 UV, no risk really, and will provide a barrier between the customer and the operator, disinfecting air and perhaps to some degree the surfaces that it's irradiating. And so that is that. And I'll close this. And if you have any questions, I'll happy to take them.
Can I just check in quickly before we start questions? Raphael has a question with Dean and with Dr. Andrew Lover, who's another guest, just to make sure that you have some time and so we can be comfortable with questions and know that you'll get to deliver.
Yeah, no problem at all.
Oh, okay. That's all. Go ahead, Raphael.
Not hearing. I think he's muted. He is muted.
No, I'm not muted.
Okay.
Dr. Nardell, thank you for a very comprehensive presentation. It was interesting to hear about the germicidal ultraviolet system. I have some questions. For example, why is it that the concentration is in upper room and not in the docks? Why this germicidal action couldn't be put in the plenums and in the docks of a ventilation system?
Well, I mentioned that a few times. If you and I are in a room together and I have COVID, your risk is because you're in the room with me. It's very little comfort to you that after the air leaves, it's going to be disinfected, especially if there's very little chance that it's going to come back at an infectious dose. which appears to be the case epidemiologically. We're not seeing much evidence of spread through buildings. We're seeing evidence of spread in rooms.
Very, very. Another question that I have. I mean, I have some concern about describing the effects of the ultraviolet as equivalent air change per hour. You know, it's not a real any air change per hour that are taking place there. It's basically
No, of course not. That's why we use the word equivalent.
So let me formulate the question.
Yeah.
The question is that
sure.
that the reason to have air change for air is to have a substantial percentage of outside air coming into a room. That is necessary in every classroom, for example.
Absolutely.
I mean, if there is a unit of ultraviolet, that's very good. But if this is going to be the only way of cleaning the air, the accumulation of CO2 will be increasing during a class. You know, I have taken measurements in classrooms, and it goes almost exponential after 1 hour. It gets to 2,000, 3,000 concentration of carbon dioxide in the room. So I am concerned that we are talking about equivalence air change per hour, when really they are not happening any air changes per hour.
No, you're absolutely correct. I should say equivalent for air disinfection purposes only.
Yeah.
We need ventilation is essential for comfort and for removing CO2, particularly providing fresh air. And we don't suggest replacing ventilation with upper room germicidal UV. It's just that comfort level ventilation, ordinarily a couple of air changes per hour is sufficient for comfort, is insufficient for airborne infection control. And if you need to supplement mechanical ventilation because your system can't provide it, or you don't want to be paying for heating or cooling 6 or 12 air changes per hour of outside air, then you generally recirculate that air within an air cleaner. I've told you about the limitations of that. Or you can disinfect the air in the room by irradiating the upper room, or with 222 irradiating directly in the room. But ultraviolet is a highly effective way of preventing respiratory infections.
Yeah, I agree.
What would these fixtures cost? Like, what would it cost if we were to attempt to budget?
Sure.
Yeah.
So a fixture costs about $800, and we dose the fixtures by the room volume. And it's really based on the study I showed you, and that's our proposal is what ASHRAE is adopting. Not that these numbers mean anything to you, but we feel that in a well-mixed room, particularly with a ceiling fan, that we're treating all of the air in the room. So the dose is for all of the air in the room. We're not treating just the upper room, we're treating all of the air in the room because it's mixing. And all of the UV that comes out of that fixture is treating the air in the room until it's stopped by some surface. So we talk about total UV output out of a fixture. We have to know that, and total volume of the room. And we dose by, again, doesn't mean anything, 12 microwatts of UV per cubic meter of room volume. And that's an evidence-based number. It comes from a study. It doesn't come from a lot of studies, but those studies we did were very difficult to do. It does correlate with a lot of room studies where they didn't actually prevent human transmission of anything, but they studied a test organism, and it's pretty similar to those numbers that come up from that method as well. So anyway, for a classroom, 1 or 2 fixtures, Generally speaking, depending on your source of electrician services, if you had a union electrician, the cost could be as much as the cost of the fixture to hang it. And if you have your own electrician do it with guidance, it could be a lot less. And then, you know, depending on the air movement in the room and the ceiling height, you might want to put in a simple ceiling fan and, you know, literally what you can buy at Home Depot. So those are not expensive at all. And then you have a complete system. Maintenance is not very expensive. It's once or twice a year, turning off the system, having somebody go up with 70% alcohol and wipe the lamps off, make sure they're still working. But it must be done to make sure that this system remains. And then once a year, you change the lamps. And the lamps are not that expensive. So that's pretty much it for the cost. I can tell you that one private school in Cambridge that got involved with this is actually taking a loan and doing every classroom. They just decided that's the way they wanted to go.
Rachel, you have a question in the chat. Did you want to voice that?
Yes, I just wasn't sure if I was going to be in the room or not. So if the ventilation isn't up to par and there's nothing else in the room, so I'll give you a little bit of backstory. I teach in Attleboro, Massachusetts, and first day of school, a kid came in knowing they were COVID positive. So our ventilation is not up to par. Should my teachers be worried? I assume yes, about the spread of COVID in the room, even though they were more than 6 feet away, because 6 feet away, people aren't being quarantined.
Well, you know, it's hard to know in any given case. Kids are thought to be less infectious, but
Not high schoolers.
Oh, high schoolers. Okay.
High schoolers. Yeah,
Yeah,
no.
that's an adult for all intents and purposes.
They're
Yeah.
adults, yes.
Okay. So, you know, we have kind of this 80-20 rule in many infections that a relatively few individuals account for an awful lot of transmission. There is no average infectious person. So I can't say on average this person would be generating so many infectious particles and it's likely to happen. It really is a bit unpredictable. And even in tuberculosis, when I did that for much of my career, the only way we find out if somebody was infectious or not is to test the contacts and find out whether they were infectious. Should they be worried? Yes, but you know, they probably have been in the presence of many other infectious, unsuspected infectious cases over the past several months and are anxious now because they know they had COVID, but they've probably been exposed many, many more times. So I think, you know, only time will tell whether any transmission occurs, and there's not much other to do it. If those close contacts remain uninfected, the chances of them being affected further than 6 feet is much less. Even though airborne, you think, oh, it can travel, both airborne and large droplets seem to act on a gradient, that the closer to the source, the greater the concentration of small particles, and the greater the chance that a large particle remains in the air and could directly hit. So it's why it's so difficult to separate out those two modes, because they behave on a proximity basis very, very similarly. In a recent webinar, national webinar, people compared the particles coming out of an infectious source as more like cigarette smoke, not that you can see it, but a kind of a cloud. And then that cloud eventually, slowly, like cigarette smoke, disperses. And once you get below a certain threshold, and we don't know what that is exactly. Some people have said 300, 500,000 particles are infectious agents you have to inhale, again, on average. Then and that's why I think when it gets into the ventilation system and diluted, pardon me?
Sorry, I was trying to log into something and it started to
Oh.
talk.
So that's why I think that once you get on the other side of the room or it gets into the ventilation system, we're not seeing a lot of evidence that just a particle or a cluster, a number of particles is resulting in transmission in other rooms. That would be my answer there. I can't predict how infectious, that person would be. Certainly there's reason for concern, and they've already tested the close proximity. The problem with testing everybody, and we saw this in TB testing for years, you'll pick up transmission that has nothing to do with that case.
We don't know that they tested everybody. The issue is that they will only quarantine people within 6 feet. So if we have schools in Massachusetts that don't have good ventilation, and
let me tell you, really, good ventilation is good for comfort. Nobody has infection control level ventilation.
Okay, so we have really bad ventilation then.
You have really bad ventilation. Now, the risk is greater. Yeah, and you'll be proven right or wrong. Your concerns will be proven right or wrong by what happens to those close. Because even with bad ventilation, the people closer are that much worse off. So if the close contacts are not turning up with COVID in the next little bit, and you have to have some guidance of who to test, even with poor ventilation. And most people are using the 6 foot 2 meter rule for testing. I'm not suggesting they should test wider than that, or certainly they could, but and I don't know how much the ventilation is a factor. We're mostly talking about proximity to the source. And dilution occurs even in a perfectly still room because of diffusion, but more so if there's a lot of air movement and ventilation. But, schools are not traditionally highly ventilated spaces. It's for comfort.
I see there's quite a few more questions, actually, Professor. I think maybe one more. I'm anxious to allow Dr. Lover to speak. So I will wonder if we could send you some email questions.
Sure, absolutely.
Afterwards.
Yeah.
And maybe we could. Is there other questions that could go through email? I know mine could. I think Christine had a question and Jean had a question.
I can go through email. I have no problem. If you give me his email, or you, how should I do it? You let me know. Yeah.
All right, then I'm just, sorry, Jean, is that okay?
Yeah. Mm-hmm.
Sorry, I'm multitasking here. My question was more about school staff like me who work in close proximity to students. So there's no possible way to have the 6 feet. These are paras, and with most schools that are adopting the hybrid model, or the phase-in model, the first phase is going to include students with intensive needs. So those are going to be, in a lot of school districts, those are going to be the students that will be in-person learning first, with staff that are literally right next to them. And that is my question, because you've talked a lot about the fact that proximity is what matters. So what do we now say to these staff members who are typically the lowest paid staff members in a school district that are working, literally touching?
Right. So there's no
students.
doubt that the risk is higher. Now the 6 foot rule, and it's not a rule, it's a guidance, I guess, really applies to the unmasked individual. When you put a mask on the source and a mask on the potential person, the vulnerable person who might be infected, you really change everything. And I'm not suggesting that there's no risk, but it is considerably reduced, even in close proximity. But, good hand washing, et cetera. But, the same kind of situation exists in the nursing home that I mentioned, where you are doing total care of people, and it's unclear whether air disinfection alone is going to make a difference when you're touching and very close. So I do think that's high risk. I think the caregiver or the teacher, what could you do? You could increase the level of personal protection, and that has a price in terms of communication and comfort. So you could wear a more protective respirator. You could wear a shield. And particularly communicating with extra need children, I can imagine that's a huge issue. And children are not always able, as you know better than I, especially special needs kids, to keep a mask on, if at all. So I think they're real problems that there are no easy solutions to. If we had all the money in the world and could use this new 222 nanometer UV directly in rooms, I think we'd be constantly sterilizing surfaces and the space between us, but that isn't going to happen anytime soon.
Okay, thank you. I also like to acknowledge that Aaron Shakow is here. He spoke to us a couple of weeks ago. I appreciate both of you for coming back, and it's really been very helpful. I'd like to just hand it over to Dean, and he would follow up with an introduction.
Yeah, so I'd like to introduce another guest to the Zoom call, Dr. Andrew Lover, who, like me, is on the faculty at UMass Amherst in epidemiology, and his area is infectious disease epidemiology. We're actually meeting for the first time over Zoom, which is more and more common, right, under the pandemic. But I invited Andrew to just talk a little bit about the UMass Amherst testing strategy, and also if we were to think about the costs involved in implementing testing at the district level, how could we think about that? Last week on the call, Mike Fidel said that districts have followed much of our recommendations around ventilation and social distancing and other things that we focused on, but there really is no testing strategy, across the state. So thanks for joining us, Andrew, and whatever you'd like to share.
Great.
Appreciate it. Yeah.
Thanks so much for having me. So a tiny bit of background. I'm working with the UMass response team. So in terms of the testing center and case investigation and contact tracing, and as well as designing a lot of adaptive testing strategies for any issues we may have in the future. Also working with the Mass DPH on some data analyses and some big antibody studies across the whole Commonwealth. And kind of COVID has taken over all of my research and all of my life, but that's a pandemic. So currently right now, we have a very reduced number of students on campus. Everyone living on campus is getting tested twice a week, with PCR being sent to the Broad in Boston. And then people that transition back and forth in terms of living off campus and having face-to-face classes are tested once a week. And there's a big compliance program with an app they have to log into for symptoms. And if they miss their scheduled testing, there's a lot of follow-up to at least find out what's going on. And so that's a really large, intensive, and resource-hungry system. So presumably, most smaller institutions will not be particularly motivated or interested in going down that kind of massive pathway. a few challenges here in Massachusetts. The structure of the state DPH can very complicate things. Most other states have a county level Department of Health, which usually has a lot of resources. Here it's all town-based boards of health, which in the bigger towns and municipalities are well resourced. In a lot of other smaller towns, it's really limited. So that's been one kind of gap in terms of the state level response. A bigger challenge in terms of planning asymptomatic testing, so people without any symptoms, is current CDC guidelines say if you don't have symptoms, you don't need a test. And so epidemiologically, that's absolutely not what we want for SARS-CoV-2. And so there's a big gap in terms of what the official evidence guidance is and what public health all think should be going on. So in terms of, it's good we're in a very proactive state that has kind of stepped in and said, these are our guidelines, which kind of supersede federal. But that's a really unusual situation that there's contradictory and, basically problematic guidance coming out of a lot of different places. In terms of considering implementing a testing program within a district or within a large school, the current tests, the PCR-based tests, are anywhere from $20 to $50 a piece, which adds up quite quickly. The newer antibody-based tests, there's a whole suite of them coming out. A couple have been approved, and there's a couple, two of the other ones that are in process. They're costed out at about $5 per test. A couple versions require a reader, which is anywhere from $70 to $100. But the two newest ones from Abbott, and then the other one is from Roche, don't require a reader. The one challenge is they do require a trained medical staff person to get the swab. So I think a $5 cost is maybe feasible in some or many school level budgets. The big challenge is lining up sufficient healthcare staff to do the sampling in a reasonable amount of time, because you really don't want kids backed up, all the way down the hall and having lots of physical overlap while they're waiting. And then to physically run that many tests in parallel is a logistic challenge. So to do kind of entry screening into the school is probably really not realistic, unless there was a really compelling reason and someone who really wanted to champion it. The second use case would be potentially looking at schools or rooms where you think there's been exposure, either at home or within the classroom. And then you can do kind of focused testing around the index case. The timing there can be a little bit difficult. If you do it right after exposure, they'll all be negative and people will still be incubating the virus, and then you'll have a problem 5 to 7 to 10 days later. So that's one challenge is getting the right tests to the right people in the right window. And all the universities in the Northeast are running tens of thousands of tests a week. And, we're all at so UMass has run, or UMass Amherst has run 2,000 to 3,000 tests a day. And usually we have one positive. So there's a bit of, in some cases, you may start to get pushback in terms of spending large amounts of money for, null results. So that's one other thing to consider within, public school budgets are constrained, obviously, especially with the budget challenges in Beacon Hill. So that's probably enough for right now. And then I'm happy to take any and all questions about, yep, Dean?
Sorry,
You're muted.
let me ask the first one. Could you say again, aside from the money, we'll return to that. That's certainly a constraint, but if money weren't a constraint, could you say again what the challenge would be about using, one of the newer antibody tests that are cheaper with some sort of entrance protocol. So we're going to test the staff and the students. Say why. I mean, I know that's a logistics challenge, but would you just speak to that again?
Sure. Yeah. I mean, the big logistic challenges would be just physically implementing a system to get students lined up while appropriately spaced and to get fast enough throughput so you don't have just problems. I mean, it's I think for younger children, it would be a larger problem, especially primary school. And then you need, so I think most elementary schools have one school nurse who may be part-time or half-time, depending on the district. And then you really run into a problem of just human resource capacity having, you'd have to do a lot of logistics to get multiple nurses from other schools physically overlapping to do it in a manageable amount of time. I mean, you could consider doing kind of round robin where you go from classroom to classroom and do, 15 or 20 or 30 per block. And that could work. But then, yeah, just having physical space to put all the tests out and record them. And I mean, logistics are not impossible. There are companies that are doing this, but they usually have, a well-resourced like nursing staff. So I think that's my biggest concern would be the personnel limitations within the nursing staff at schools.
Yeah. One other question. Now, these newer things that are coming online, are these the type of tests that can produce more rapid results? I mean, like what's the processing look
15
like?
minutes, I think, is the design time for the Roche and the Abbott. But then there's also a bit of a problem. Usually you have to read it in exactly 15 minutes. Mm-hmm. So you have a whole block of tests in there and you've got to have a timer going, and if you get too many piling up. Yeah, so I've done a lot of this for other infections, and it can get, the logistics can be challenging. All solvable, but with a lot of logistic support. Yeah. And I mean, the other thing is you're definitely going to miss infections. They're less sensitive than, the regular drive-through testing. But that's the trade-off. So you can do more regular routine testing and, probably come out ahead. I mean, it's just physically impossible to do PCR on a whole school. So this is the best option, I think.
In Lowell, they have a kind of a sampling strategy. Mm-hmm. Can you talk a little bit about what kinds of sampling strategies might be effectively used and for who?
So this is like a enriched or targeted sampling strategy at Lowell, or?
Yeah, so like, for example, in a dorm, they're not necessarily testing everyone. Mm-hmm. They're just testing a few people and making assumptions about what it means.
Okay, so you can do a population-based sample where much like a political poll, you get a very representative sample of who you think is in your population and test just those. That's really hard to do really well because there's always subpopulations that you're maybe missing. I mean, for public schools, it's a bit easier because you have them physically there, whereas universities, you have a lot of people transitioning. There's also adaptive sampling where if you think there's a problem in one dorm, you can do focus testing there. And if you see a certain number of negatives, you'll be reasonably confident you're okay. There's something called freedom from infection, which is from actually designed for testing like cattle for export. And you can kind of optimize how many tests you run with a certain level of confidence that you're not missing infections. All those are a bit complicated to set up. Obviously, a school is a bit simpler because you have a really good sense of your attendance list, so that helps. But then the physically planning that kind of a survey is a bit time consuming. So that would be one caveat. There's a comment in the chat box that the Lowell strategy is maybe a little problematic. Yeah.
Yeah, Miles, did you want to
Miles, yeah.
ask another question too?
Yeah, I was just curious about the strategy in Lowell compared to the strategy in Amherst. In Amherst, students who have what we've been told, and I work with a local two locals in Amherst and two in Lowell at UMass, and what we were told in Amherst is that part of the strategy is to try and get students tested if they have any kind of connection to the campus that's formal, and then offer it to other students in the community. And I think it's twice a week they try and get students
So anyone
to
that's
test?
physically who's in the residence halls is twice a week. Then there's another subset of students who just have one face-to-face class but live off campus, and that's once a week. And then there's a larger block that are students who are all online learners, but went ahead and took their lease locally because they already signed the paperwork. And that's the one that's been the most challenging. So we're doing a huge amount of work to try and figure out exactly who they are and how many people are there and incentivize them to come in for testing.
Right. And then the strategy in Lowell is you have to either live on campus or you have to have what sounded like, the way it was described, was 2 contacts with campus. So for example, if you just had a face-to-face class, you wouldn't necessarily get tested. Or if you worked on campus, but you didn't live in the dorms and weren't taking face-to-face classes, you wouldn't necessarily be tested. But if you were taking a class and worked on campus, then they would try and test you. And to me, that sounded, and the justification, well, obviously one is it's a lot of tests to do and it's expensive. But the other one was, if you're in a class, there's not much risk.
Yeah, so all the classroom spaces are designed to be not close contact under any circumstances. And that has to be the assumption.
Right. But you don't assume that people teleport into class.
Yeah, well, that's one of the challenges that Lowell has a lot more stable population than Amherst. I mean, basically the population here doubles. So there's, I think, a higher threshold for community level testing, or testing of people who are living in the community. So that's a little bit different, I think. But I mean, I think really the thing is all of these testing paradigms are predicated on people obeying social distancing when they're not on campus, and all of the other things that we're all dealing with. So there's plenty of examples of it spiraling rapidly. Notre Dame and UNC, and so
Boston College.
Yeah, it's a bit unclear. They had the swim team had a problem, and then and then Providence College just quarantined all off-campus students indefinitely, I think, which is logistically a bit of a head scratcher. But
Can I just ask one more question about Amherst?
Sure.
I know that so Jeff Hescock is one of the people in charge of campus public health, right? And he was telling us that some schools use different ways of measuring the effectiveness of their testing programs. And he really tries, from what it sounds like, he tries to make sure that Amherst has a really thorough testing program, very conservative about trying to protect public health.
Yep.
And he was explaining that there are different ways that schools are kind of characterizing how they're testing and the results of their testing, and that
well, if you look on a lot of dashboards, there's some that people do a lot of funny things in terms of data reporting. Like the whole question is, what's your denominator in terms of who's being tested, how often?
Right.
And so, it can be a little challenging to even unravel what's being done.
Jean, you have a question?
Yeah, mine is actually on a kind of a different vein. I am a resident of Amherst, so taxpayer in Amherst for a very long time. Also work in the Amherst Public Schools. And I have raised this question to Representative Mindy Dahm about the possibility of UMass opening up some time frame for testing for town and or school employees as part of a town gown strategy. And I don't know if that has even been discussed.
Yes, it has been discussed at multiple levels, and
okay,
it's definitely possible and being considered. Right now, there's
that's good to know.
Yeah, right now there's some limitations in terms of the number of tests we can run a week through the Broad Institute in Cambridge, but we're building some in-house capacity, and that's the long-term plan.
Okay, that's good to know. Thank you.
Sure.
Any more questions? I suppose while our guests are all here, we should open questions for everyone, and maybe they have questions for each other. I don't know, but just want to make sure it's a really special opportunity. Ed, I promised a friend of ours, Ken Wirtz from the Massachusetts Facilities Administrators Association, that I'd ask a question about bipolar ionization. I don't know anything about it, but he said that there are districts that are starting to look into it. Have you heard anything about that? You're on mute, Ed. Ed, can you unmute?
Yes, that helps. I've had some conversations with companies that do this. What it is a way to make a filter more efficient without increasing resistance. So bipolar ionization essentially uses electrostatic forces to attract particles to the filter. And so the holes in the filter essentially can be bigger, essentially. And there are a number of good, and it seems like it works really well. The problem is that you are still filtering the air, either in the return duct with the issues that I raised, not that it would increase resistance that much, but that it's not necessarily the right place to place the intervention. So when talking to one of these companies, I said, well, as much as I'm not a huge fan of air cleaners, that's the place to put your technology. If you build an air cleaner with a less resistant filter, you can probably move more air in a room. And if for rooms where that's what they want to do, what people want to do, that would be a good kind of air cleaner to have, either with the bipolar filter. You know, the problem is there are so many people trying to make a buck on mitigation of this pandemic, many with good ideas, many with some good ideas and bad ideas, and it's really hard to keep them separate.
That's, I think, a question that the committee has to grapple with a lot, especially with what we're hearing tonight. What is good information and what isn't good information, and how do we get it to people? I was very keen on asking what I saw answered in the presentation, that this is a system, the UV system, could be implemented now, but what kind of information can we get to people, and what, do you have any studies or data that might answer people's questions about the adverse health effects?
Yeah, there's a lot of, I mean, I have a number of papers that I've authored, and then there's the official documents of the CIE that I showed. There really are, I mean, I've been working in this area a long time, but there really are no serious health effects of upper room germicidal UV at all. The worst you get is some eye irritation if it's badly installed, and that can be fixed. And when you compare it to the health consequences of COVID, there's no comparison. So, you know, we're always balancing risks. Now, there's no risk at all to a ventilation system and no risk at all to a room air cleaner. It just happens that those approaches are less effective in my view. So, you know, so we've been using, again, you saw that this has been used in the 1940s. This is not new technology. There are no mysteries about upper room UV and its risks, short-term, long-term. There is a lack of familiarity and a certain lack of expertise. You're hard-pressed to find people who have done it before to help you, but it can be done.
And I'd like to go back to similar question for Andrew. Given that, you know, we need to coordinate information that we get here with locals, and you're obviously doing a ton of things. What would you recommend to us, or what guidance could you give us to, you know, help locals to push for better testing right now?
It's definitely going to have to be coordinated with the local boards of health, and they can maybe provide some extra capacity. But depending on the school district and the board of health, that may be a big challenge. And DPH is stretched really thin everywhere. Yeah, I mean, so UMass, we've been pulling on the nursing students quite a lot. Because they need practicum hours, and it's a great experience for them. So you could consider other schools of nursing. But yeah, I mean, the big challenge is the entire healthcare sector is just really, really stretched. In terms of prioritizing resources, certainly you want to look carefully at the districts that have the right demographics and a sufficient number of cases, and probably prioritize resources there. Yeah, you have to be very judicious about where you decide to try and do these kinds of things, or you may just be not wasting money, but not so effective in terms of your impacts. But yeah, so the lack of guidance on testing is a huge challenge. I mean, generally for, you know, all of the CDC's historical pandemic preparedness, there's these beautiful, you know, pull down menus and check boxes that say, oh, here's how to plan your pandemic response. And you open the folder and start. But we're kind of in uncharted territory, unfortunately.
Are there any other questions? I mean, it's been, yep. Ed, did you have, no, oh, okay.
I guess I would just echo what Andrew said about the unusual situation in Massachusetts, not having counties, which turn out to be a reasonable size entity to provide local, or not local, regional public health. And as the TB officer for Massachusetts for 18 years, it was, you know, oftentimes the health officer for a small town is a clerk with no medical background whatsoever, and they're asked to assure the public health of a community. On the other hand, as Andrew also said, we have a very progressive and excellent Central Department of Public Health, although stretched thin. And it's true that in California, Massachusetts would be a large county. So there's that. But I think I'm surprised there isn't more guidance for schools do this.
Andrew, could you go out on a limb and make any predictions about what you think is going to happen? In
looking at the medium to long term, or
yes, yeah,
okay. Sure. We will not have a vaccine in the next several months. That's even if there was a vaccine tomorrow morning, it would be essentially impossible to manufacture and distribute enough quickly. So basically the glass vials you need for vaccines have to be virgin glass. You physically can't buy enough right now anywhere on the planet. One of the other challenges is that the two lead vaccines require cryogenic storage, which makes distribution just a logistic nightmare. So all of that together means the vaccine's quite a ways off. And yeah, so we'll probably see cycles. So going into the winter, we have to expect some upticks in infections just because so many people are spending more time indoors and closer proximity. That's, yeah, the kind of the magnitude of that will depend a bit on social behavior. Yeah, so probably another year, frankly, of some version of this. It's
for a little hopeful note.
It's really difficult to see any. Yeah, I mean, there could be a global vaccine that is coming forward sooner, but the internal licensing and kind of political barriers, I think, could complicate that. Yeah, and the whole herd immunity strategy is not feasible. You can look at Sweden and see basically all of their long-term care facilities are just massive fatalities, and yeah, so that's, yeah, all of our options are pretty poor. I have to be honest.
There was a talk last week at Harvard School of Public Health by, maybe you know the name, Andrew, but she is a lead investigator, lead author on a number of the papers for the Moderna vaccine. Mm-hmm. And happened to be when she was doing her postdoc, somebody said, hey, why don't you study coronaviruses vaccines? And she was working on MERS. At the same time, Moderna was developing this messenger RNA delivery system, and the two together made a tremendous leap in this vaccine development. And one of the things that was encouraging, first of all, she said that the results in primates, not published yet, so she couldn't go into detail, are spectacular, reducing not only the disease severity or disease prevalence of incidence of disease in people vaccinated, but also reducing viral load very dramatically, meaning people who get infected are not likely to be infectious very quickly, which is great. And also that there are actually better antigens now than even the Moderna vaccine is testing, but you have to stop at some point and make a vaccine or you never have one. And secondly, that they're working hard, as maybe that's what you were implying, a coronavirus vaccine that would literally be effective against a variety of coronaviruses, the next coronavirus, so to speak. And that's very hopeful as well. But all the logistics that Andrew mentioned are certainly a barrier to getting out of this particular hole in the next short period.
Yeah, agreed. Yeah, I mean, the rate of research is absolutely staggering. I mean, there's been like 40,000 publications in the last 8 months, which is just, yeah. So that's really encouraging that there's so much money and momentum and so many concurrent vaccine candidates. Yeah.
Andrew, I have a question. So I'm at UMass Lowell with Scott, and I'm fortunate to be on this committee too, which is a committee for kind of like worker health and safety and public health as well. So from your perspective and your experience now, you're in your perch at UMass Amherst, to what extent do you think the role of kind of like active union advocacy for public health, what role has that played in your success at being able to set up this good testing system, which on the surface, it looks great, and it looks like it's functioning really well. I mean, what role, do you have any lessons for us to kind of like, you know, to push us in our work to have, you know, unions be kind of like at the forefront of the larger community health and public health?
I mean, I think, again, being in a state with really strong unions makes a large part of this possible. The kind of institutional support to make all this happen certainly was coordinated across all the different unions. Yeah, it's funny because, you know, environmental health and safety has never really had to deal with infectious diseases before. I mean, certainly like in laboratory settings and, you know, clinical labs, but in terms of, you know, large scale routine public health, this is all new, doing population level programs. So certainly the kind of logistics capacity and even having this conversation right now across campuses, I think is a really strong thing. And certainly the unions have a lot of pull on Beacon Hill. So that's probably the strongest, just to keep, yeah, in terms of funding for the local level response. I think that's the most critical part. And then potentially some technical assistance from Jamaica Plain. I don't know. It's difficult with such centralized public health capacity.
So if there are no more questions, oh, there are, of course, Miles.
I'm sorry.
That's okay.
So just quickly, I don't know if you're involved in any of the, you're on the epidemiological end, but you know, a lot of places in the state are going to the Broad Institute at, you know, Harvard and MIT, but it's my understanding that UMass is also going to be doing, at least for the asymptomatic testing, or actually for more than just the asymptomatic testing, but they're going to be doing all of their testing on campus, both symptomatic, which I guess they already do, and asymptomatic, and that UMass might actually be a resource for other folks in Western Mass, so that other public entities, schools, et cetera, can do testing. And do you know anything about that part?
Yeah, I do, quite a bit actually. So we're finishing all of the clinical laboratory regulatory paperwork to get a fully approved clinical lab set up. It's like a 900-page dossier. Like it is unbelievable, the level of accreditation and compliance paperwork. And so there'll be so you probably know about ISLE, the Institute for Applied Life Science. This is associated with that, and it'll be a fully certified staffed lab to do really high throughput, high volume testing like the Broad. And the idea is to have that as a resource for the whole central and western half of the state. The timelines are changing every day. And then there's a lot of other kind of global supply chains for all of the reagents you need are really difficult. So there's kind of, there's.
Is October still in the sights, or is that?
It's been discussed. It may happen sometime in October, or it may slide into November. It's hard to say.
Even November would be great.
Yeah.
Thanks.
Sure.
You're muted, Dean.
Yeah. One more question. This is more on the kind of union advocacy side. So, money is an issue, capacity and resources are an issue, but should we be encouraging our members to be insisting on some kind of testing protocol? I mean, even if it can't happen, should we be pushing that it happen? I mean, do you see what I'm saying?
I mean, certainly, I think. Yeah. I think pushing the agenda now and saying this is something we really should proactively consider systems and funding and organizational capacity, and at least have a response plan on the shelf to reference. I think that will certainly help pushing for funding at whatever level needs to happen.
And sorry, and a quick follow-up. And so what do we say to the pushback from health professionals who say, well, you know, masks and social distance and ventilation are enough? Like, you know, how do we, you know, what do we say in favor of a kind of dated, you know, kind of testing data-driven kind of thing?
I think that the easy answer there is that perfect people doing perfect activities and always wearing their masks is probably enough. But, you know, people are never perfect. And I think school children especially are, you know, that's a big challenge, and college students.
Right.
Yeah, so I mean, I think there's definitely, there's certainly an economic aspect that can be made. I mean, testing is expensive and logistically difficult, but if it can keep you from shutting down and keeping continuity of education, that's, you know, certainly a smaller investment in going forward. I mean, there again is like a bit of a disconnect in terms of the federal guidance. So there's a danger that someone can point to the CDC website and say, well, this says you can't do asymptomatic testing. And that's been a challenge actually in terms of the insurance companies as well. They won't reimburse in general. Hopefully that will change at the federal level. I have to assume it will. Like, it kind of has to, but I don't know when or how. So that's one challenge there.
Okay.
Yeah. I think certainly pushing on Beacon Hill and saying this is a good investment in keeping the state running well and staying off of the front page of the paper. Certainly.
See no more questions, I think. Thank you very, very much.
Certainly.
Our other guests have left already, and I didn't have a chance to say thank you again, but certainly will. And if there are more questions, I hope we can.
Certainly. Yeah. Feel free to email me anytime. Happy to help. Very important questions that we're going to be dealing with for the foreseeable future, certainly.
And I think the last couple of questions from Tom and Dean are indicating that we really want to help with your agenda if we can. Do you have any, you know, if you want to, I'm assuming you're in MSP or?
Yeah, oh, certainly. Yeah.
So.
Yeah, I'm happy to be a union member. That's why we're all doing what we're doing. Yep.
Yeah. Yes.
So if you need, certainly I'm happy to. I mean, my time is a bit chaotic now, but certainly.
Right. Okay, so there were a couple other items on our committee agenda, and okay. I don't know how people are feeling right now because both of them would be new topics. It might be better if we postpone it, but first one being about stress, and Christine did some research and forwarded some materials about some things that are available online through what is it, the local public health, or no, it's through the Mass Department of Public Health. So maybe we could just touch on that and talk more if people don't want to stay online right now. I don't know. I'm asking, how do people feel?
I think they're tired. I mean, we could discuss it another time and let them think about it, you know, what their people will need.
Yeah, thank you, Christine. I think it's good for us for now to start gathering resources so that in a week or so, or when we get inundated with requests, we'll have all of the resources together and then can send them out rather than having to dig for them. So it would be good for all of us to start searching for more resources on dealing with stress. I mean, most school districts are doing the mindfulness, and which is fine, but we're talking about really, really high levels of stress that people are experiencing, both those that are doing the in-person instruction and those that are having to do the enormous lift of remote learning. And the amount, I don't think the public understands the amount of work that is involved with remote learning and what is being asked of educators in order to make it work. Scott, I think for the other agenda item, which is the state legislators, that might be something that we can start talking about via email and reach out. I know that Representative Dom said that she is available on Thursdays. So this time frame works for her. My only caveat for myself is I'm not going to be available the second Thursday of every month due to the other committee that I'm on.
Yeah, so I mean, so related to that question is what is our agenda for the rest of the year, and do we really, are we going to be meeting once a week, which is a pretty heavy load.
Yeah, I agree.
But it seems like things just keep happening. So I don't really know what to say about that. And I'm feeling the stress too, and I'm not even in the classroom. So
do you want to, can I make a suggestion that maybe we skip a week and maybe do bi-monthly meetings and see how that goes? And while, so not meet next week. And in the interim, we can all start looking into the stress, workplace stress. I know we had the surveys that we did, and was it in the spring? We started to do, or last fall. I think it was before all of this happened with the school closures.
Yes.
We had done a little bit of work on workplace stress.
yeah, well, sure. We could look at that. And also we developed a special project on stress and race, which is a very, I think it's a very important topic right now.
Absolutely.
In fact, I saw something in the Globe today that I thought was relevant, and although I don't subscribe, so I didn't read the article. But anyway, yeah. So how do people feel about that? Do you want to meet next week or meet in 2 weeks? Laura, you had unmuted, so I think you were going to say.
I think I'm really busy with back to school and I have been reassigned. So every week is tough for me right now. I'm not opposed to the every other. I was just going to say that.
Okay. How about you, Kevin? What's going on with you? How are you doing?
Good. I think it's probably apropos at this point in time to meet bi-weekly as we move forward. School is quite challenging right now, not being in the classroom. So yeah, I agree with the people that are in the classroom right now would tend to think that the bi-weekly meetings would work best at this time.
And Mike Fatal, can you weigh in, or maybe actually, do you think it would be possible to talk a little bit offline with what we might be, how we could look at the whole year and how you might need us with what's happening with the different campaigns that are going on?
Yeah, I'd be happy. So sorry, I'm switched to a different computer and camera's faulty in this, but I'd be happy to do that. And if it's most efficient, Scott, if you and I could just set some time aside and do some planning and bring it back to the group, or whatever is best on your end, but happy to help with that planning. If it's 2 or 3 or 4 of us, and then bring it back to the committee, that might make the most sense. Or if you want to do it as a full committee, either way.
Well, I don't ever want to exclude anyone, so that's how I tend to feel about that. But I'm certainly willing to do it in the name of keeping things moving when everybody else is occupied. So I'd like to I will reach out to you and find out if there are others who are willing to do that.
That'd be great.
So okay, I think that then we're done for today. If anybody has any other comments. If not, thank you very much.
Thanks,
Very
Scott.
nice.
Thank you again
Okay,
so
thank
much.
you guys.
Thanks very much.
Thanks, Scott.
All right, have a good night, everybody.
Good work, Scott.
Good night, everybody.
You too.